Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. What's going on with your patient's arm? Well, as you can see, it's somewhat swollen and erythematous. We call this erythromelalgia, and it's a rare symptom of Polycythemia Vera. We're going to talk about this and much more in today's presentation, which is Myeloproliferative Disorders Pathology. This is covered in your book. I know you've been reading it because you're not procrastinating. You've been doing a great job. You're smart. You know what to do. If you don't have it already, you can scan this little QR code thing and it'll take you somewhere to get to the book, okay? Anyhow, myeloproliferative disorders are neoplastic proliferations of myeloid cells. You see all these myeloid cells in this image here? You can tell they're myeloids because we have some bands and neutrophils. We have some promyelocytes and metamyelocytes here. Now, myeloproliferative disorders typically occur in late adulthood around the average age of 55 years old. Myeloproliferative disorders are associated with a couple things, which include leukocytosis, which is a high white blood cell count. You remember those cutoffs, right? 10,000, remember that? Also, the bone marrow will be hypercellular. So if you did a bone marrow biopsy, histopathology assessment will show a packed marrow, packed with myeloid precursors. In myeloproliferative disorders, there is an increase in all the cells of the myeloid lineage. Myeloproliferative disorders are characterized based on the dominant myeloid cell that is produced. Complications of myeloproliferative disorder include high risk of hyperuricemia and gout because of that rapid turnover of neoplastic cells. Also, myeloproliferative disorders may transition into acute leukemia or progression to marrow fibrosis. Chronic myeloid leukemia is due to the neoplastic proliferation of mature myeloid cells, in particular granulocytes and granulocyte precursors, like we can see here in this image to the right, showing chronic myeloid leukemia actually affecting the peripheral blood. Note the marked increase in white blood cells, aka marked leukocytosis, with the granulocytes and a left-shifted myeloid population. Because we shouldn't have myeloid precursors out in the peripheral blood. We should mainly only be seeing neutrophils, mature neutrophils for the most part. But we're seeing many promyelocytes. Also keep in mind that an increase of basophils is characteristic of chronic myeloid leukemia. Chronic myeloid leukemia is typically driven by the Philadelphia chromosome, which you know is translocation 922, which results in the production of a BCR-ABL fusion protein with higher tyrosine kinase activity. Now let's think back to biochemistry with all those signalings and those pathways, those cascades. You remember that when tyrosine kinase is activated, a number of downstream processes are implemented, are turned on. So when BCR-ABL fusion happens, more downstream elements are turned on and there's more cell generation, which in this case is negative and leads to this neoplastic process. Fortunately, Imatinib, which inhibits tyrosine kinase activity, can be used as first-line treatment for chronic myeloid leukemia. Some common features associated with Chronic myeloid leukemia includes splenomegaly, or just spleen enlargement. And when that happens, it usually indicates an accelerated phase of the disease. Also note that chronic myeloid leukemia can transform into acute leukemia. Due to a mutation in a pluripotent stem cell, chronic myeloid leukemia can progress into acute myeloid leukemia or acute lymphoblastic leukemia. For the most part, if it does transform, it's more likely to be acute myeloid leukemia 2 out of 3 times. Otherwise, it's acute lymphoblastic leukemia. Leukocyte alkaline phosphatase, also known as LAP staining, distinguishes chronic myeloid leukemia from a leukemoid reaction. Leukocyte alkaline phosphatase is negative in chronic myeloid leukemia. Leukocyte alkaline phosphatase is positive in leukemoid reactions such as reactive neutrophilic leukocytosis. The granulocytes in a leukemoid reactions are what cause the leukocyte alkaline phosphatase activity. You remember this image? Can you tell me what translocation is happening here? Philadelphia chromosome 922 associated with chronic myeloid leukemia. In B, we specifically see fluorescence in situ hybridization. We have a couple normals indicated by the green and the red. And then look at that, we have a fusion occurring, giving that yellow. You see this image with the packed myeloid elements, some bands, some metamyelocytes, some promyelocytes. This is chronic myelogenous leukemia. Let's move on to Polycythemia Vera. Polycythemia Vera, also known as PV, is due to the neoplastic proliferation of mature myeloid cells, particularly red blood cells. Too many erythroids being produced by the bone marrow. And you can see actually on this peripheral smear, erythroid precursors, those circular cells with the dark nuclei. We shouldn't have erythroid precursors out in the peripheral blood, but in this case we do. Now, you remember what this is called, this classic finding? Erythromelalgia. It's rare in real life, which means it's probably common in testing situations. In Polycythemia Vera, granulocytes and platelets are typically increased. 95% of the time, Polycythemia Vera is related to a JAK2 kinase mutation. Many clinical symptoms of Polycythemia Vera are associated with viscous blood. Some symptoms of Polycythemia Vera include blurred vision, headaches, higher risk of venous thrombosis, a flushed face because of the congestion causing plethora, as well as itching, particularly after a shower or a bath, and this is due to histamine release from the mast cells. Treatment of Polycythemia Vera includes phlebotomy and hydroxyurea. Without medical intervention, Polycythemia Vera typically results in death within 2 years. Reactive polycythemia must be distinguished from Polycythemia Vera. In Polycythemia Vera, the SaO2 is normal and erythropoietin levels are low. However, in reactive polycythemia, the SaO2 is low and the EPO is elevated. Reactive polycythemia with elevated erythropoietin and normal SA2 levels are typically caused by ectopic renal cell carcinoma production of erythropoietin. Isn't that fascinating? Here in this image, we have an example of histopathology from a patient with Polycythemia Vera. You can pause and read, but please pay attention to the megakaryocytes that are pronounced and increased throughout, as well as the fibrosis. Again, Polycythemia Vera is highly correlated to a JAK2 mutation, and the bone marrow biopsy is likely to show an increase of erythroid precursors and megakaryocytes. You see all the megakaryocytes? Do you see all the erythroid precursors? Particularly in B, because the one in the A panel is what we expect to see in normal situations. Okay, let's move on to essential thrombocythemia. Essential thrombocythemia is due to the neoplastic proliferation of mature myeloid cells, in particular platelets. Here in this image, we have a histopathological representation of a bone marrow aspirate in a patient with essential thrombocythemia. Red blood cells and granulocytes are also raised in essential thrombocythemia. Keep in mind that essential thrombocythemia is also typically due to a JAK2 kinase mutation. Symptoms of essential thrombocythemia are related to excess abnormal platelets. So there is a risk of bleeding and or thrombosis in this condition. And in rare cases, ET may actually advance to marrow fibrosis or acute leukemia. Let's talk about myelofibrosis now. Myelofibrosis is due to the neoplastic proliferation of mature myeloid cells, and particularly megakaryocytes. Myelofibrosis is also related to JAK2 kinase mutation in 50% of cases. Platelet-derived growth factor, which megakaryocytes overproduce, is what causes the marrow fibrosis associated with myelofibrosis. In myelofibrosis, splenomegaly occurs due to extramedullary hematopoiesis. The histology of myelofibrosis is characterized by a leukoerythroblastic smear with teardrop red blood cells. They look that way because they had this squeeze out of the marrow, distorting their shape, making them look like teardrops in the peripheral blood. There are also nucleated red blood cells present in the peripheral blood, as well as immature granulocytes associated with myelofibrosis. Patients with myelofibrosis have an increased risk of infection, thrombosis, and bleeding. Yikes. And that wraps up this lecture. Great job. You're learning so much, you know so much, you're reviewing so much. You're going to do great on all of your examinations. Keep studying, and I'm rooting for you. You got this.